Oke, Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam.
Okay. Good to see you, Aziz. Aziz is always on the camera. So that shows, and the rest, those who on the camera, it shows how enthusiastic they are. Okay, so Alhamdulillah, inshallah we will commence our session today with Kitab. Bismillah. So inshallah today is the Arafah day, and tomorrow we'll be celebrating Adil Adha with our own way, no crossing the state. Okay. So I guess today's topic is there be not much interference from me because it's a very technical. You can ask the presenter any question that you want. Okay. Okay, so I think without further ado, I pass over the floor to the presenters.
Thank you, Prof. So, Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. And very good morning, IB, to all my fellow friends, to Prof. Ramli and my fellow friends. So, today, me and my colleagues will be presenting a seminar entitled Sleep Disorder. All right. Okay, so how to remove this? Anybody know how to remove this noti?
Oh.
Sebab macam first time jadi. Abaikan. Okay, I think I'll proceed. Alright. So this is our outlines and contents for today's seminar. Alright. So the first presenter will be me, Muhammad Farisifan bin Abdul Hadi, metric number 17122077. Alright, so I will be presenting on physiology of sleep. Alright, so basically sleep simply not just to rest ourselves, but it have many other functions. For example, sleep is essential role in many vital physiologic function, and with sleep we can conserve our energy. And then interestingly, sleep also helps in brain waste clearance by a system called glymphatic system, in which as you know, CSF, cerebrospinal fluid, on the day it is relatively slow moving and inactive on the day, while at night CSF is faster paced, and it will help in clearance of the brain waste. And then with sleep also, our immune system and also including hormonal system will reboot, and sleep also helps in our cognitive function, in which knowledge in which we learn will be stored in short-term or long-term memory while sleeping. And then sleep also helps in our performance, helps in preventing diseases, helps us to be an alert person, and also helps in psychological condition.
Faris,
Yes.
do you still remember the hierarchy of needs by Abraham Maslow? You want that? Tengah.
Hierarchy of
Ada berapa stages? 5 stages ni. Hierarchy of needs. Ingat. What about the rest? Ingat? Tak ingat hierarchy of needs. Hierarchy of needs. Seorang tak ingat. Yang basic needs kan? Biological needs, the bottom level. So sleep, is it considered as basic needs? Cuba Google. Jawapan dia yes kan? So sleep is essential. Sleep, food, apa lagi? Safety is next lah. And then sex sebenarnya adalah the basic needs. Okay. So maksudnya the idea here, if let's say you have a patient with insomnia, you really need to help them with something. Okay. You know.
Okay, thank you, Prof. All right, so I'll proceed. Before that, I want to remove this notification first. All right, I'll proceed. Right, next, electrophysiology of sleep. So basically, sleep consists of two stages, which is the non-rapid eye movement, or NREM, and also REM, rapid eye movement. So basically, and then this NREM, NREM consists of four stages, and also REM. Okay, so basically, why is it called as REM? Because in this stage, our eye is rotating back and forth. All right, so we'll go one by one. So this is our sleep cycle. Stage 1, stage 2, stage 3, and stage 4 is considered as non-REM and also REM stage. All right. So firstly, regarding the NREM sleep. All right. So in stage 1, to easily understand is that in stage 1 we have it is the lightest, and we have theta waves in stage 1 and also a vertex shift shape sharp wave. Okay, so and it consists of 2 to 5% of total sleep lasting for around 1 to 7 minutes, and it is easily interrupted in this stage. And then stage 2, basically it constitutes around 45 to 55% of total sleep and lasts approximately 10 to 25 minutes. And in the EEG waveform, we can identify K complexes, which is a little bit like an ECG complex and also a sleep spindles wave. Right, and then moving on to the stage 3, which is also called as the deepest sleep stage. It is a slow wave sleep, and it constitutes only about 3 to 8% of sleep, lasts only a few minutes. And in EEG waveform, we can identify a delta wave. So this waveform is called a delta wave. And stage 4, it is the EEG waveform is the same as stage 3, and it lasts approximately 20 to 40 minutes and makes up about 10 to 15% of sleep. All right. So to summarize NREM, basically stage 1 we have theta wave, stage 2 we have K complex and sleep spindles wave, and stage 3 and stage 4 we have delta wave, and it is also called as the deeper sleep. Right. So next, moving on to the REM sleep. So REM sleep basically it tends to be shortest, usually lasting less than 10 minutes, and later the REM periods may last 15 to 40 minutes each. And in EEG waveform, we can identify the sawtooth waveforms, and in this stage also, the person is atonic and immobile and have partial or full penile erection. And dreams during REM sleep are typically abstract and surreal. Right. So to summarize the sleep cycle, so we can see that in this graph, the cyclical nature of sleep is regular and reliable, and the NREM sleep constitutes about most of our sleep cycle, and REM sleep constitutes around 20 to 25% only. And the REM sleep increases as the night progresses. Right. Next, besides sleep cycle, there is also the regulation of sleep wake, in which we have two processes. Either the person is having sleep generating system or wake generating system. So in this graph, we can see in process S, also called as sleep generating system, it is a process in which it promotes sleep, and it accumulates across the day. It peaks just before bedtime at night and dissipates throughout the night. While process C, it is a wake promoting process, and it is regulated by the circadian system, in which I will explain after this. And it maintains wakefulness and build across the day, and it declines at bedtime. All right. So this is basically the graph showing how the sleep generating system or wake generating system acts. So for example, in this sleep generating system, to easily understand is that this sleep process, or as I mentioned before, process S, it is regulated by neurons that shut down the arousal system of the body. Thus, it will allow the brain to fall asleep. So in this graph, we can see that the neurons, uh, uh, the pathway of the neurons is that the neurons in the pons will intermittently switch from NREM to REM sleep, and these neurons will send outputs to the lower brainstem and spinal cord, causing muscle atonia and also REM sleep. And loss of these neurons can cause profound insomnia. And then moving on to wake generating system, it is an ascending arousal system from the brainstem, in which it will activate the four brain structures to maintain wakefulness. So the pathway, the easy pathway is that the neurotransmitter will enter the hypothalamus, and then it will pick up the input from the nerve cell and then enter cerebral cortex, and thus it will activate the nerve cell and prepare them for interpretation and for wakefulness. All right. So a little bit about the circadian rhythm. So the rhythm are generated by neural structures in the hypothalamus that function as the biological clock. So this circadian rhythm is essential for the wake generating system, in which we can see that the circadian rhythm is regulated by the melatonin hormone. So the melatonin hormone, also called as, we can call it as a calming hormone. So it release is started at night, and it will the melatonin release stops at in the morning while waking up in the morning. So this circadian rhythm will organize our daily behavioral and physiological rhythm in according with the external day-night cycle. So I think that's all from me. These are my references, and I will pass on the presentation to the next presenter.
What about sleep? When it will happen? At what stage? At what cycle of sleep? The dream will happen.
The dream, from what I understand,
Boleh you show us the normal sleep cycles? This one. Very interesting. When do you think the dream will happen?
from what I understand, the dream will be at the REM stage.
Okay. Was it at the initial part of sleep or towards later on? You could still remember about the dreams, or you can still recall the dreams.
Yes, Prof. I cannot hear clearly.
What stage of sleep that we tend to remember our dream or recall our dream? Jawapannya towards the end, kan? Because as you can see there, we will have more REMs towards the end of our sleep cycle.
Yes.
Okay. Okay. Cuma kalau nanti, I think the next presenter will talk about nightmares. Nightmares is different. Nightmares is, you can ask the presenter at what stage the nightmare will happen. Okay. Thank you.
Okay, Prof.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Is my voice audible?
Yes.
Okay. Assalamualaikum warahmatullahi wabarakatuh. So, Bismillahirrahmanirrahim. Inshallah, I'll be presenting about insomnia, or the most common used term by most of us. Basically, it gives the meaning of inability to sleep. So from the word insomnus. Next. Let's delve in a bit about the epidemiology to know about how common is this condition within our population. So first thing is the persistent and severe sleep disturbance affects at least 1 in 10 adults. It means about 10% to 25% in older adults presented or affected by this severe sleep disturbance. And 1 year survey of population shows prevalence rate of between 30 to 45% in adults. And symptomatic wise, 10 to 15% experience daytime impairments, and 6 to 10% have symptoms that meet criteria for insomnia disorder. As for the gender-related prevalence, more prevalent among female, with a ratio of 1.44 to 1 a gender ratio. And 40 to 50% individuals with insomnia also present with comorbid mental disorder like major depressive disorders or other form of mood disorders or other mental conditions. Okay, next. First, before we go even further, let's define first what does it mean by insomnia. So the etymology from Latin word insomnus, sleep, which means means negations of any things, that the suffix of negations that comes, anything that comes after it becomes negated. Somnus means sleep, so it means sleepless by language, but also defined as difficulty or inability to sleep. However, definition by International Classification of Sleep Disorder, second edition, describes insomnia as a disorders of initiating and maintaining sleep. It means that there's a further explanation on that term. However, just start with that, initiating and maintaining sleep. That's the main point there. Next. So it can be classified into whether its duration is short-term or acute, and chronic or episodic or recurrent in terms of duration. For the sleep period, it means that within the sleep period or like stage they mentioned before by our friends now, the sleep it can be divided into 3, which is sleep onset insomnia or initial insomnia. Middle insomnia means awakening in the middle of the sleep and then inability to return back in a sleep state. And then late insomnia, which means by terminal insomnia or early awakening insomnia. Based on international classification of sleep disorder, it was divided into etiology. Next. So if you can see that the sleep disorder can be divided into a psychophysiological insomnia. It's like it means that there's a conditioning factor, like you have negative association with sleep, therefore it will affect your sleep in some sense. And then paradoxical insomnia, idiopathic insomnia, insomnia due to mental disorder like comorbid disorder, presented with insomnia, inadequate sleep hygiene, more or less like lifestyle problems. Insomnia due to medical disorder, due to, for example, pain, or again mental disorder also. Insomnia due to drug or substance adjustment insomnia. So basically based on etiology, even divide classification of insomnias. All right, next. So the clinical features, the most essential features of insomnia is dissatisfaction with sleep quantity or quality. It means that we need to first have the subjective perception or the interpretation of the patient about the sleep experience, and also the effects on his or her daytime daily function, with complaints of difficulty of initiating and maintaining sleep. So back to the definition of insomnia just now. So diagnosis of insomnia requires 3 main components, and it also next to the after we diagnose based on duration, based on severity, and also based on the period. So diagnosis of insomnia requires 3 main components. First, persistent sleep difficulty. It means there's a certain period of time that we need to know how long had it been besetting upon our patient. And adequate sleep opportunity, it means that there's nothing wrong with the sleep schedule. There's nothing wrong with the not the shift worker, for example. It's already have adequate amount of time to sleep, but still fail to fall asleep. associated with daytime dysfunction. Daytime dysfunction will be further explained after this. So subjective interpretation or perception of sleep by the patient presented with such problem, it can be vary based on the patient's ability to describe how the sleep pattern affecting his daytime function. Like for example, non-restorative sleep. It is the most common presentation, and you can read the further description about the non-restorative sleep in DSM-5 into this. All right. So next. So the clinical features, the continuity continue from the previous slide. So more towards how we define the difficulty initiating sleep. It's like a subjective sleep latency greater than 20 to 50 minutes, means that when you cannot, when you are just lying on bed doing nothing, not even scrolling Instagram or doing something that cause your brain activity to be activated, like you know that when you have this playing with screen, and then it's like affecting your brain perceive as it's still daylight and daytime, and it will activate your brain, and that cause your brain to have to not achieve the arousal state that cause you to sleep. So it is like without doing anything like that to activate your brain, you still have the problem to initiate sleep. So sleep latency greater than 20 to 30 minutes is quite significant to define as difficulty initiating sleep. And difficulty maintaining sleep means that subjective time awake after sleep onset greater than 20 to 30 minutes. And then early awakening at least 30 minutes early before the scheduled time, and or before total sleep time reaches 6.5 hours. This was taken from DSM-5, however, it's subjective to sleep variations, whether it's like little sleepers or someone that can sleep which not so not require much time to sleep to have adequate amount of sleep, right? So it's like pretty much subjective, but on average we can say that if the total sleep time does not reach 6.5 hours, then it means early awakening, then it's something wrong. It's different case for those yang kuat qiyamul lail. All right, daytime impairments. How do we find daytime impairments? The more common described as fatigue, less common daytime sleepiness, and impairment cognitive performance. More or less it means there's have disruption or difficulty to pay attention or to have concentration during daily tasks, and memory impairment because when you fail to focus, then that is like because focus is like a gateway for memory, so it will also impair your memory system. And also associated with mood disturbance like irritability, mood lability, depressive or anxiety symptoms that do not meet criteria of the specific disorder. And that's the reason why when patients have a symptom of depressive or anxiety symptoms, we need to ask also about the sleep, because we need to know whether the sleep or the insomnia is a causal attribution or just a clinical manifestation of the mental disorder, right? So that which one comes first, it's more or less like you need to know which one comes first so that we can manage the problem, or we can manage the patient properly and adequately. Right, next. Next is this DSM-5 criteria. So as mentioned before, it was based on diagnostic of the insomnia along the is judged along the dimensions of first frequency and then intensity and duration, as well as impact on daytime functioning and quality of life. It means that all of these aspects will be assessed from the DSM-5. First thing is, as mentioned, the essential features of insomnia is a predominant complaint of dissatisfaction with sleep quantity or quality, more that duration is superior than the quality, the subjective perceptions of the effectiveness of rest associated with one or more of the following symptoms. Again, it is being divided into three, the initial or middle or terminal insomnia. Next. And then the sleep disturbance affecting daily impairment, be it social, occupational, educational, academic, behavioral, or other important areas of functioning. For example, if we as a student, we have problem to focus in class, maybe we need also to have a look at our sleep pattern or our sleep habit. And then the sleep difficulty occurs at least. This one is about the period or the durations of the problem. The sleep difficulty occurs at least 3 nights per week. This one is the frequency. The sleep difficulty is present for at least 3 months. This one is the durations of the problem. Make it chronic or acute or episodic or recurrent. The sleep difficulty occurs despite adequate opportunity to sleep. This one is the one, the clinical features means that previously I mentioned about the summarized version of the clinical features. However, the DSM-5 is more on the precise or the criteria to make it more precise and understandable, and can be as a guideline for clinicians to diagnose insomnia. And the insomnia is not better explained and does not occur excessively during the course of another sleep-wake disorder. It means exclude other form or other causes of like narcolepsy, breathing-related sleep disorder, circadian rhythm sleep-wake disorder, parasomnia, or substance abuse. Then we can say that this is primary insomnia. Because the existing mental disorders and medical conditions do not adequately explain the predominant complaint of insomnia. It means that, for example, the patient had problem with mental disorder. However, the insomnia comes before, or maybe the patient had medical condition that caused patient to have chronic pain. However, the patient already have insomnia or sleep problem before patient have pain. So it does not adequately explain the presence or the problem or the complaint of insomnia on this patient. So that's how we see the criteria of the insomnia on patients. Next. Next is the another side note, specify if this with non-sleep disorder mental comorbidity like major depressive disorder or anxiety problem, including substance use disorders, with other medical comorbidity with other sleep disorder. More on how we specify the condition. And episodic, persistent, recurrent. Episodic defined as symptoms at least 1 month, but less than 3 months, doesn't really meet the criteria of chronic or acute. And then symptoms last 3 months or longer. That one is for persistent. And recurrent, 2 or more episodes within the space of 1 year. Means that episodic is more like doesn't meet the criteria of acute, and persistent or chronic. So it goes to episodic. Recurrent is the frequency of the symptoms to arise on the patient within the space of 1 year. Also note that insomnia can be diagnosed as primary or independent condition, or is a comorbid with another mental disorder. For example, major depressive disorder or medical condition. For example, pain or another sleep disorder. Okay, next. About the development and cause, it can occur at any time during life. It can occur in children, it can occur in adulthood, adolescence, more frequent or more common in older adults, less frequent in childhood. And that's the reason in the, if you aware in the DSM-5 mentioned about if in children, it been described as the caregiver explain about the problem. Right. Insomnia can be situational, persistent, or recurrent. Situational means adjustment insomnia, like there's a stresses in life and then causing the patient to have sleep disturbance and makes the patient to develop insomnia later on. Also goes with the steps, the 3 Ps: precipitating, perpetuating factors, and also predisposing factors. For example, the patient have rapid changes in the sleep schedules, and then the propensing factors like the environment doesn't really support the patient to adapt properly with the changes of that, or there's the life stresses, for example, that can precipitate also the insomnia. With predisposing factor like vulnerable to sleep disturbance, it can further worsen the condition of this insomnia and develop into chronic insomnia or any form of insomnia disorders. Recurrent or episodic usually associated with the occurrence of stressful events. Again, if the stress is being removed, the insomnia will expected to resolve. However, if it's not resolved, then it will change into like something, if it persists more than 3 months, and then it becomes chronic. So it means that it can, from recurrent episodic, it can becomes, if not being treated well or not being managed well, it can become chronic insomnia. The development of insomnia also in relation with conditioning factors is more like the explanation on the psychophysiological insomnia part. All right, next. on how to manage. So dah gerak ke belum slide? Alamak. And okay, management of insomnia. It can be summarized into two parts, which is drug therapy and also psychological therapy. The drug therapy is the hypnotic drugs. There's a benzodiazepines or non-benzodiazepines. Right, so benzodiazepines like zolpidem, diazepam. In bracket is um, the brand name for the drugs. Should not be prescribed more than 2 weeks because it can make the patient to have withdrawal effects. Long-acting or short-acting sleep medication. Each medication will be used to treat different type of insomnia. So like long-acting we use to treat like if the patient having problem to maintain sleep, then being given flurazepam or clozapam. If the patient have an ability to initiate sleep, then it will be given zolpidem or triazolam. Also, melatonin receptor agonist also being used for initial insomnia to help patient to initiate or to for the sleep onset problem. For psychological therapy, you use the most common one is not the common one. The one we can use in practice is cognitive behavioral therapy. From the name, we can guess that it uses a combination of cognitive and behavioral techniques to overcome dysfunctional sleep behaviors. First, about the dysfunctional sleep behaviors, more like the lifestyles, misperceptions, and distorted thoughts, more on the cognitive part, so that we can try to alter the perceptions or how the patient perceives sleeps to change and to the understanding about the importance of sleeps, like how the sleep pattern, how insomnia can affect, and there's a component in cognitive behavioral therapy which specified for insomnia, or the short form CBT-I. You can read that later on if you want to know more about that, but I will just give components after this. All right. So next, benzodiazepine. This is the drugs taken from up to date. You can read there's a benzodiazepine and non-benzodiazepines. There are other drugs actually, but I did not include it here. Maybe I will put it to this. Sorry. So you can read this later. Next. And then management, the cognitive behavioral therapy, for example, the vicious cycle of poor sleep being given is explained like this. If you have problem with sleep, and then where it will affect your mood, you have mood disturbance in daytime, and then you have depressed symptoms, and the depressed symptoms also can cause you to have negative perception about the sleep, and then the depressed symptoms or the depressed mood can also affect sleep, and then you have the all around things like it becomes one reinforce the other, like that lah. So negative emotions, negative behavior, negative thoughts. So the cognitive behavioral therapy is to challenge the negative thoughts and also to challenge the negative behavior so that it can help to break the cycle. So first is sleep education and sleep hygiene. In sleep education, the component is like the need for sleep and its function, sleep patterns across its lifespan, sleep as a process with stages, those kind of more about how patient knowledge about sleep, the importance of sleep. And then the sleep hygiene, teach the patient or educate the patient about the importance of sleep hygiene for a better quality of sleep, about the bedroom, comfortable sleep, the lighting of the room, and the temperature, the sounds, those kind of thing, right? And then after that, about the stimulus control treatment, is more towards the how define individual sleep requirement, establish parameter for bedtime period, eliminate daytime napping, so that patient will not have perception like, okay, I already sleep during the day, I don't need sleep at night. Those also need to be altered about that. The sleep restriction therapy being so, particular in terms of sleep when you feel drowsy and then wake up, like it's like you're trying to build new behavior, cognitive control, thought suppression. Thought suppression, for example, like you suppress the activity of your mind so that you can achieve arousal state much earlier in the early onset of sleep. Imagery and relaxation, more like meditations, hypnotic technique, and then cognitive restructuring and paradoxical intention. So those are the components in the management of cognitive behavioral therapy. So in terms of, however, next, the advice on management, general perspective, non-pharmacological treatment using cognitive behavioral therapy procedure should be preferred over pharmacological treatment in case, however, in cases of severe persistent insomnia. However, hypnotization should be recommended mainly for short-term or occasional use only. And there's some evidence shows that combinations of both CBT and also pharmacological may temper down the effectiveness of cognitive behavioral therapy, what we call it, cognitive behavioral therapy efficacy, or when you use CBT and at the same time you use pharmacological treatment, the pharmacological treatment can also, like, making the CBT does not really put into application much. So it can be effective for certain patients, but it's not like you need to try first with CBT and then pharmacological treatment, and if not both, and if not work again, then we need to try and error for a lot of treatment modality for the patient. And that's how the understanding about the management of the insomnia in patient. But first, need to exclude other form of problem, like problem with playing with device before sleep, or the sleep hygiene, all those stuff. Okay, I think that's all from me. I didn't put my reference, but my reference is mainly three books: Kaplan and Sadok, Oxford, and also DSM-5.
Okay, thank you, Aziz. Any comment? Can you go back to the first slide? Any comment from the rest? Hope you're not sleeping. Although the topic is sleep. Okay, if let's say you look at the epidemiology, is it common? Is insomnia common or not?
Common.
Common. And then why it is more prevalent among females? Any particular reason?
Can I guess? Is it because of hormone?
Okay, leave it that question first. Now next is okay. I think the next point should be the age line. Kalau let's say you look there, the age as the person is getting older, they've been more likely to develop insomnia, as what Aziz mentioned here. So that is under epidemiology. Okay, can you proceed in terms of classification? Next. Okay, you can classify. Okay, the way how Aziz classify is something very practical and clinical, which means sometimes we ask, okay, is it initial insomnia ataupun intermittent insomnia or terminal insomnia? So because it's depend on the pattern of sleep difficulty. What is other way we classify insomnia? This is very important. I think the Aziz has not mentioned about this aspect. Anybody?
Is it primary or secondary?
Okay, very good. How do you know? But it is not in your slide.
Yeah.
Okay. Because this kind of classification is very practical in the sense that, okay, I'll leave it as it is first, because if let's say I answer, then I'll give you the why we classify as primary and secondary.
It will affect our management, because if it's primary insomnia, then we treat the problem. However, if it's secondary, then we need to treat the cause that caused the insomnia to present or to manifest in the patient.
Okay, which one is more common, primary or secondary?
Secondary.
Secondary, okay. Secondary is more common. I would say in terms of percentage, probably 70 are secondary or 80 are secondary. Okay, right. Secondary means what? It's caused by how we
The
divide. How do we divide secondary? It caused by what?
comorbid disorder,
Give example.
like major depressive disorder or psychosis, bipolar. I mean,
Okay.
mental disorder.
Yeah. Okay. So jawapannya is a psychological or
Physiological.
physical.
Oh.
Physiological. Okay. If the medical, other medical problem also may cause. Can SID, cancer, all that, pain, that can cause insomnia. So psychological or psychiatric or non-psychiatric. And so psychiatric is more common atau psychological more common. So for example like depression, anxiety, these two are very common. Kalau ada insomnia, you try to find out the etiology behind it. Is it commonly is depression, anxiety lah when we look at the prevalence. And of course, other type of psychiatric disorder may also cause insomnia, schizophrenia, bipolar. Tapi the percentage, the percentage itself is not that high. So here, this kind of classification is very important in the sense that in your management, so you need to find the etiology behind it. Not just to treat the insomnia, but you need to treat the underlying cause. That's the reason. And okay, come back to primary. What kind of condition it be common for primary insomnia? What does it mean by primary? Jawapannya?
I mean, the insomnia being exclude other causes of non-psychiatric and psychiatric, then the insomnia is just isolated symptoms, isolated condition.
Yeah, betul. Agree. You answered correctly. So primary insomnia, there is no other reason. It's just patient develop insomnia without any reason. So in what condition patient will tend to develop, in what kind of patients by demographic profile patient may develop? Jawapannya adalah elderly. Elderly. So in elderly, very common. They're not having anxiety, they're not having depression whatsoever, but they have insomnia. So this is another way of classification. So come back to tadi soalan yang saya kata just reserve yang saya demografi.
Women lebih senang tu dapat insomnia.
Itulah jawapan dia. Why? Kalau you tengok prevalence of depression, siapa yang common? Kan? It's among women. Anxiety, again among women. Kan? Dalam psychiatric disorder ni, nanti you may ask why among women? It's a lengthy answer.
Like the cause due to menopause, the set of menopause.
Menopause boleh lah, tapi dia punya insomnia not that bad. Insomnia, hot flush and so on. Yalah, mungkin. Tapi jawapannya adalah depression lah. Because they're common dengan depression. Okay. Okay, in management in general, I think the first line will be, jawapannya adalah, apa dia management?
Cognitive behavioral therapy, psychological.
Jawapannya sebenarnya adalah sleep hygiene. Itu number
Sleep
one.
hygiene. Oh, okay.
CBT ni sebenarnya very structured. Kalau you understand CBT ni, not many patients are suitable for CBT and not many patients were keen for CBT. Ataupun mungkin I rasa why CBT is one of the modalities sebab mungkin because CBT sebenarnya untuk anxiety dan depression sebenarnya. Tapi insomnia boleh jugalah, tapi I think the effect of CBT mainly towards anxiety and depression. Jawapannya sleep hygiene. Okay, number 2, yang you ingatlah benzodiazepine dengan zolpidem. Dua ni you kena ingat. Okay. Zolpidem ni senang benzodiazepine. Okay, I think that's all the comment from me. Unless you have any question.
Thank you.
Okay, no question, then proceed.
Yeah, you can hear my voice. So, Assalamualaikum warahmatullahi wabarakatuh. My name is Nur Hafizah binti Muhammad Bashir. My matric number 1712220. So, I will proceed our presentation today with hypersomnolence and also narcolepsy. So, hypersomnolence can be defined as excessive sleepiness, and or it also can be defined as a condition when a person experiences significant episode of sleep, even after having 7 hours or more of quality of sleep. And the excessive sleepiness, hello, okay, the excessive sleepiness can be associated with with any other sleep disorder, such as obstructive sleep apnea and circadian rhythm sleep wake disorder, which will be discussed by my friend later. Okay, so in DSM-5, hypersomnolence are being described as hypersomnolence disorder, which is characterized by a complaint of excessive sleepiness, which can be expressed into two main categories of symptoms, which are first, excessive quality of sleep that refer to extent of nocturnal sleep or involuntary daytime sleep. And the second one is deteriorate quality of wakefulness that refer to difficulty awaking or inability to remain awake when required. Okay. Next. Okay. For the causes, what I found that the researcher is not yet found the exact causes, but the possible causes could be increase in the brain chemical that can cause the sleepiness. This increasing of the chemical can act much like a sleeping pill, and they believe that there is interaction of substance called gamma aminobutyric acid or GABA, which are responsible for promoting sleep in the brain. This situation also we can see when we sedate the patient during the surgery, where the sedative medication act on the same GABA substance that to keep the person sleep. Okay, next. Okay, this is the risk factor. The risk factor could be psychological stress or alcohol use that can increase the risk of hypersomnolence. And other than that, it can cause, other than that, the viral infection like HIV, pneumonia, infectious mononucleosis, and GBS can evolve into hypersomnolence within months after the infection. Hypersomnolence also can appear within 6 to 8 months after the head trauma. Okay. Other risk factors such as family history and medical history also important to increase the risk hypersomnolence disorder. Okay. Next. Okay, for the symptoms, patient or individual with hypersomnolence disorder will usually have no difficulty falling asleep, and they also have high sleep efficiency, where the duration of the major sleep episode or nocturnal sleep more than 9 hours, and the patient, most of the patient will experience continuous arousal upon waking in morning or daytime napping, where they will appear awake, but his or her behavior may be very inappropriate, with memory deficiency, disoriented to time and place, slow meditation, and speech. However, this will return to normal within 30 to 60 minutes. Patient with hypersomnolence disorder also will have a daytime nap nearly every day, regardless of nocturnal sleep duration. And this excessive sleeping may cause problem at work, school, or other daily activities. Okay, next. Okay, to diagnose, we use DSM-5, where it include A, self-reported excessive sleepiness, despite a mean sleep period of at least 7 hours, with at least one of the following symptoms, which are first, recurrent period of sleep or lapse into the sleep within the same days, or prolonged mean sleep episode more than 9 hours per day, and difficulty of being awake. Okay. B, the hypersomnolence occur at least 3 times per week for at least 3 months, and it will accompany by significant distress and impair in cognitive, social, occupation, and other important areas of functioning. And this hypersomnolence is not better explained by or does not occur as exclusively during the course of another sleep disorder, such as narcolepsy. Okay, this hypersomnolence also not attributed by the physiological effect of a substance, and last one is a coexisting mental disorder or medical condition that does not adequately explain the hypersomnolence. Okay, next. Okay, continue. Hypersomnolence disorder can be specified into duration and also severity. For the duration, we have acute, subacute, and persistent. Where acute, the symptom is less than 1 hour, and 1 month. Subacute, the condition is between 1 to 3 months, and persistent more than 3 months. And for the severity, it is based on the degree of difficulty maintaining daytime alertness, where can be divided into mild, moderate, and severe. For mild, it happened 1 to 2 days a week. Moderate, it happened 3 to 4 days a week. And in severe, it happened almost all days a week, which is 5 to 7 days. Okay, next. Okay, next is the management. For the management, we can advise the patient to establish bedtime routine and limit distraction before going to sleep, or having a good sleep hygiene, which can help them to have a good night's sleep. And for the pharmacological, we can treat the patient by giving awake promoting substance such as modafinil as a first line treatment, or traditional psychostimulant such as amphetamine. Okay. Next, I will proceed with narcolepsy. So next. So narcolepsy is a condition that characterized by excessive sleepiness and auxiliary symptoms that represent in interaction aspect of REM sleep into waking state. This condition is neither a type of epilepsy or psychogenic disturbance. It is an abnormality of sleep mechanism, which is the REM inhibiting mechanism. Okay. For the narcolepsy, it frequently begin in adolescence or young adulthood before the age of 30 years old. Okay. Next. Okay, for the symptoms, there are four main symptoms, which is sleep attack, cataplexy, hallucination, and also sleep paralysis. Okay, first is sleep attacks. The most common symptoms that occur in patient with narcolepsy, where patient will have the episode of irresistible sleepiness that lead to 10 to 20 minutes of sleep. And then they will feel refreshed at least briefly after. This condition can occur at inappropriate time, while, for example, while eating, talking, or driving. And this kind of condition can be dangerous because it can lead to the automobile and industrial accidents. Next is catalepsy. Catalepsy is a brief episode of weakness or sudden loss of muscle tone, and it varies in severity and may represent with dropped jaw, head drop, weak knee, or paralysis of skeletal muscle. And the patient often remain awake during the cataleptic episode. This catalepsy this catalepsy is usually triggered by laughing, anger, or excitement. Okay. Next is hypnagogy and hypnopompic hallucination. It is a vivid dream-like experience occur at the sleep onset or on awaking, and it can be in form of auditory or visual, and it can also be mistaken as a nightmare. And then sleep paralysis. Sleep paralysis is the uncommon symptom where the patient awake and conscious but unable to move a muscle. It may persist for more than a few seconds, and it can occur while falling asleep or waking up. Okay, next. Okay, this picture shows the catalepsy phase where when the person being triggered by strong emotion, and then it become a weakness in the face, and then lastly completely catalepsy. Okay, and then next. Okay, this is DSM criteria for narcolepsy. Okay, the criteria include A, recurrent episode of irreversible need to sleep, lapsing into sleep, or napping occurring within the same day, and must there must have been occurring at least 3 times per week over the past 3 months, and the present and they need the presence of at least one of the following symptoms, which is one episode of catalepsy, or the second one is hypocreatine deficiency, where we can measure through the CFS fluid, and then presence of the REM through the polysonography. Okay, next. Okay, for the management, narcolepsy, there is no cure for the narcolepsy, but the symptoms we can manage by first the schedule nap, lifestyle adjustment, taking care of general health. And other than that, we also can prescribe drugs such as modafinil to reduce the number of sleep attacks. And other than that, we can also prescribe selective serotonin reuptake inhibitor to reduce the catalepsy. Okay, next. I think that okay, this is my reference. I think that's all from me. Is there any question? If no, okay, if no, I pass the presentation to Atika.
Bismillahirrahmanirrahim. I am Atika, and today I have 2 subtopics to be presented. The first is breathing-related sleep disorder, and second circadian rhythm sleep-wake disorder. Let's go one by one. Okay, the first one is breathing-related sleep disorder. Sleep disorder, which is caused by breathing problem, and the DSM-5 has included those 3 problems. The first one is obstructive sleep apnea hypopnea, OSAH. Second, central sleep apnea, CSA. And third, sleep-related hypoventilation. Let's go to OSA first. Next. Okay, the definition. Yeah, PNEA is breathing. So apnea, no breathing or cessation of breathing. For how long? For 10 seconds or more. Meanwhile, hypopnea is the reduction of breathing for 10 seconds or more. Therefore, so how we could identify a patient has apnea or hypopnea, because the patient is sleeping and they don't even realize that they didn't breathing. So we do sleep study or polysomnography. And I believe that we have encountered this during our specialized posting. Okay, so obstructive. Okay, next. What DSM says about the diagnostic criteria. It is either two criteria. The first one is the patient has at least 5 obstructive apnea or hypopnea and presence of nocturnal or daytime symptom. Nocturnal symptom such as snoring, gasping, or breathing pauses during sleep. Meanwhile, for daytime symptom is daytime sleepiness, fatigue, waking up unrefreshing despite of adequate duration of sleep. And of course, all of the symptoms didn't caused by any other mental or medical condition. That is the first criteria. Or the second criteria is the presence of 15 or more obstructive apnea or hypopnea per hour of sleep, regardless of any symptom. Okay, next. After we have diagnosed OSAH, we have to further classify next. We have to further classify the severity in according to the apnea hypopnea index as shown, mild, moderate, and severe. Why? Because we want to assess the efficacy of the treatment later on. Okay, next, we move on to the risk factor. What makes a patient susceptible to have obstructive airway during sleeping? First, being a male. Second, of course, obesity. Third, retrognathia. Retro means posterior. So the lower jaw is set further back compared to the upper jaw. Next, micrognathia, small jaw. And besides that, of course, a positive family history of OSA can lead to OSA too. Moreover, the genetic syndrome that reduce upper airway patency, such as Down syndrome, Treacher-Collins syndrome, and besides that, presence of adenotonsillar hypertrophy, and commonly in children, those who has menopause, and last but not least, many various endocrine diseases such as acromegaly. Okay, next about the management, how to manage OSA. The main goal is to alleviate the sign and symptom, and we want to improve the quality of sleep, and we want to normalize the apnea hypopnea ratio. So what can we do? We can give patient education. Educate on what? We can educate on the risk factor. We can educate on the natural history of the disease. Educate on the consequences of untreated OSA, such as MVA. So we have to advise the patient to avoid from driving during sleepy. And besides that, we can modify the behavior of the patient. Let's say the patient is obese or overweight, we can advise the patient to weight reduction and advise on sleep position, change from supine position into non-supine position, such as lateral recumbent, and advise to stop taking alcohol. And besides that, of course, the effective treatment is by using CPAP or continuous positive airway pressure. And for those who had mild or moderate OSA, they can opt for oral appliances such as mandibular advancement and tongue retaining. That is the alternative treatment besides CPAP. And last but not least, those who are in need of surgical intervention to reconstruct the upper airway, they may do so. Next, we move on to central sleep apnea, CSA. Okay, this condition, this apnea is caused by a central problem. So when the breathing center at the CNS, they are malfunctioning, therefore, the signals sent to the respiratory muscle will be poor, hence develop a poor respiratory effort, hence lead to apnea. And this is more common in elderly, and the presenting complaints such as insomnia, sleepiness, sleep fragmentation, and sleep fragmentation. Okay, next, how to diagnose it. DSM-5 says it is 5 or more central sleep apnea per hour of sleep, and of course, this is not explained by another current sleep disorder. Okay, now we move on to. Okay, after we diagnose, we have to further specify the type. The first one is idiopathic, which is idiopathic. Second, Second is chain stroke breathing. This condition, it can be caused purely by CNS, higher brain center, CNS, or it can be a secondary to other medical conditions such as congestive cardiac failure, renal failure that cause hypoperfusion to the brain. So the characteristic pattern of this chain stroke breathing is they have a periodic crescendo, decrescendo variation followed by apnea, crescendo, hyperventilation, then hypoventilation, then followed by apnea, crescendo, decrescendo, apnea. Okay, that's it. Next. The third cause is opioid use. So how it can cause apnea? Because we know opioid, it causes respiratory depression by activating the mu receptor at the medulla. Okay, that's it. After we have specified, then we specify the current severity of the patient in order to assess the treatment later on. And we can assess by determine the frequency of the breathing disturbances, the extent of associated oxygen desaturation, and sleep fragmentation. Okay, next. Last disease of breathing related sleep disorder is sleep related hypoventilation. As the name reflects, this patient doesn't have any apnea or hypopnea, but the patient experiences hypoventilation instead of having a normal ventilation. So the diagnostic criteria is having a decreased respiration associated with elevated CO2 levels. Of course, elevated CO2 level, it is explainable because reduced respiration can increase CO2, that's it. And it is not explained by any current sleep disorder. Next. After we have diagnosed, we have to specify either it is idiopathic, congenital, or comorbid. Okay, for idiopathic, as our presenter mentioned, during sleeping, our muscles are kind of freezing. That's why we didn't kick the person who sleep next to us. We didn't frequently move around, move here and there. So this applies to the respiratory muscle too, which in turn it can lead to idiopathic hypoventilation. Second, congenital central alveolar hypoventilation. This is a rare condition, and usually they presented during perinatal period with cyanosis, shallow breathing, apnea during sleeping. And lastly, comorbid sleep-related hypoventilation. This occurs as a consequence of a medical condition. Any medical condition that can lead to hypoventilation, it can lead to this problem. For example, in pulmonary disorder, like COPD, interstitial lung disease, for neuromuscular or chest wall disorder, like kyphoscoliosis, cervical cord injury. And drug also, it can lead to this hypoventilation, such as benzodiazepine and opioid. Yeah. And obesity, it can also lead to hypoventilation. Okay, then we specify the current severity according to those degree of hypoxemia and hypercarbia during sleep, and the evidence of an organ impairment. And take note that the presence of blood gas abnormality during wakefulness is an indicator of greater severity. Okay, that's it. That is all about breathing related. Now we move on to circadian rhythm, sleep-wake disorder. Next. As mentioned earlier, circadian rhythm is our biological clock. It tells us at what time we have to sleep, etc., etc. So let's say this person who usually sleep at 10 p.m. suddenly they have a night shift for a week. So this whole 1 week, the patient will experience insomnia, daytime sleepiness, etc., etc. Why? Because his biological clock is demanding him or longing for him to sleep at 10 p.m. Meanwhile, his actual sleep-wake schedule didn't allow him to do so. So this is why This is one of the example in circadian rhythm sleep-wake disorder, in which there is a misalignment between the desired and the actual sleep periods. Okay, that's it. And as mentioned about previous presenter too, our biological clock is being influenced by all those things: bright light, social cue, stimulant, activity. So next, whenever all of these factors they fail to re-entrain the circadian rhythm, so disorder will occur. Next, what DSM says? DSM says there is a persistent or recurrent pattern of sleep disruption of that thing, the misalignment between the desired and actual sleep periods. That is criteria A. Criteria B, it will lead to excessive sleepiness or insomnia or both. And criteria C, it says that it will affect our function. Okay, that's it. Next, we move on to type of circadian rhythm sleep disorder. The first one is delayed sleep phase. Delay in the time. Okay, that is so lengthy. In short, delayed sleep phase is biological clock that is being shifted later, usually 2 hours or more. Just imagine like burung hantu, they sleep late and then morning they feel fatigue, morning drowsiness, but more alert in the evening and early night stay up. Okay, and this delayed sleep phase. These are more common in mental disorders such as depression. Next. Okay. Second, at once sleep phase. Just now it delayed. Now it is being at once. Biological clock is being shifted 2 hours or more earlier than the conventional usual biological clock. And this time around, just imagine like being an early bird. Okay. Next. The third one is irregular sleep-wake time. This time around, it is not delayed, it is not shifted, but it doesn't have any recognizable pattern of sleep. There, the absent or pathologically diminished circadian rhythm, and it is characterized by no major sleep period, and sleep is fragmented into at least 3 periods during 24-hour day. And this irregular sleep-wake time, it is commonly associated with neurodegenerative disorder such as Alzheimer, Parkinson, and neurodevelopmental disorder in children. Next. Okay. Non-24-hour sleep-wake. What does it mean? This condition, it has an abnormal synchronization between an individual's biological clock and the Earth 24-hour light dark cycle. That's why it is more commonly happen in a blind or visually impaired person, because these kind of people, they have less light receptor. So that's why they don't really recognize day or light. Next. Last one is shift work type. And this is like just my very first example just now. And usually when this patient revert to day work, not night shift anymore, the symptom resolve. Okay, now we move on to the management. First and foremost, lifestyle and behavior therapy. We can advise the patient to have a good sleep habit, like maintain a regular sleep-wake schedule, even during weekend or during vacation, and avoid from sleeping at the evening, morning, during the day. Yeah. Next, bright light therapy. Bright light therapy, we give a high intensity of light in order to reset the biological clock in accordance to the Earth 24-hour system. And we give this bright light therapy in morning for those who has delayed sleep phase to correct back, and we give this therapy during the evening in those who has advanced sleep therapy, advanced sleep phase. Okay, next. Okay, besides that, we can give drug such as melatonin or modafinil. Last but not least, we can opt for chronotherapy. Chrono is time, therapy is therapy. So time therapy. So what is time therapy? Time therapy is we try to delay the bedtime for several hours on successive day. Say, for example, this patient has delayed sleep phase and usually sleep at 3 a.m. So chronotherapy, the next day, the patient has to sleep at 6 a.m. Then the next day, 9 a.m. Next 12 p.m., 3 p.m., 6 p.m., 9 p.m. until the patient get the desired bedtime you want. Okay, that's it. Okay, last but not least, this is the comparison among all of those types. So I believe that's all from me. Thank you.
Okay. It's already 1.5 hours. Any question?
Just I have a question. Just now in the first part, the obstructive sleep apnea hypopnea, you mentioned about apnea hypopnea index and then apnea hypopnea ratio. What is that and how we calculate that? Thank you.
Actually, we use that thing polysomnography, and it can tell us how many apnea, hypopnea. So index ratio sama je kan? Okay, so when the next slide, kalau lagi banyak index tu lagi severe lah. Macam tu lah.
So meaning yang 15, 30 ni number of apnea or hypopnea in 1 hour lah. That one.
Yes. What I understand.
Okay. Yeah.
Okay. Obstructive sleep apnea ni is to tell you the truth, is more of ENT topic, not really psychiatry. I think probably I think you have learned it during the specialized course. Okay, any other question? Please remember about parasomnia. Ada satu soalan aku. Itu je lah. Dulu lagi. Ada soalan lain? Okay, I think if no question, we should thank to all the 4 presenters who have done an excellent work.
Prof, ada one more presenter for parasomnia.
Oh, you can parasomnia. Oh, we haven't covered
Yes.
parasomnia. Oh, okay.
Yes.
Okay, please stay
Okay.
awake. Another topic, parasomnia. One question will come up from you.
Yes. Alright. So I will continue with parasomnia next. Parasomnia is a disorder of partial arousal from sleep and is a diverse collection of sleep disorder characterized by behavioral or physiological phenomena occur during or caused by sleep. So there's some disorder during sleep. Okay. Next, parasomnia can be grouped into NREM, non-REM sleep arousal, REM. Parasomnia usually related with REM sleep and others, and you can see the disorder under each group. Next, first we will discuss on non-REM sleep arousal, which are sleepwalking
yang
and
sebut
sleep
tu kan?
terrors.
Ini yang sebut tu lah.
Yes.
Okay, nightmare. Okay. Important. Okay.
Yes. Alright. Next, this is the DSM-5 criteria for non-REM sleep arousal disorder. And as you can see, in the criteria, we can see that it is a recurrent episode of incomplete awakening from sleep, and it's usually in the first 1/3 of the sleep. And it can be specified whether sleepwalking or sleep terrors. And there's no or only little dream imaginary is recalled by the patient. So also patient will have amnesia for the episode. So they cannot remember when the sleepwalking or sleep terror happened, and this condition does not cause clinically significant distress, does not attributed for any physiological effect, or not coexisting with mental and medical disorder. And under sleepwalking type, we can also specify with sleep related eating or sleep related sexual behavior, sexsomnia. Okay, next. Sleepwalking can be defined as an individual arise from bed and ambulate without fully awakening, which means that the person can move around walking without having consciousness. It's also called as somnambulism. And sleepwalking is common in children, which peak at 4 to 8 years old and usually resolve spontaneously after adolescence. Adult sleepwalking is quite rare and usually have, if present, has a familiar pattern or secondary to another sleep disorder. Sleepwalking episode may range from sitting up, attempting to walk, or doing semi-purposeful action. Often they can interact with environment. For example, they can avoid tripping over object. However, some may react inappropriately and may resulting injury to that person. Some severe case, the sleepwalker may commit an act of violence. And they also difficult to awaken as they usually happen in non-REM. So non-REM is deep sleep, so they are difficult to awaken. And if arousable, they will appear confused. So it best to lead them to bed instead of awaking them. And attempt to awaken them may result in the sleepwalker will react violently to defend themselves as they are in confused state. Next. As I mentioned before, the specialized form of sleepwalking is first sleep-related eating, where the person eating in their sleep and have no memory of eating. And maybe the next morning there is an evidence of eating, but they have no memory of doing it. And next, second is the sexsomnia or sleep-related sexual behavior, where the person involved in sexual activity, for example, masturbation, sexual intercourse during sleep without any consciousness. Next is sleep terror, which is characterized by sudden arousal with intense fearfulness. As mentioned in DSM criteria at first, I mentioned that it happened in the first state of sleep, in which in deep stage 3 or stage 4 sleep. Usually, patient will start screaming and cry, and accompanied by behavioral manifestation of intense anxiety bordering on panic. Autonomy and behavior which correlated with fright usually presented with a sleep terror episode. They usually sit up in bed, unresponsive to stimuli, and if awakened is confused and disorientated. And the person may speak up but usually incoherent. And as mentioned in DSM-5, the person will not remember any of the episode, but sometimes can only remember fragment of frightening static image. And history of traumatic experience or frank psychiatric problem is often associated with adult having sleep terror, and fever and CNS depression withdrawal can potentiate sleep terror, and sleep deprivation can provoke and exacerbate sleep terror. So before I proceed, I would like to highlight that sleep terror is different from nightmare disorder that I will explain later. Okay. Next, we continue with parasomnia, usually related with REM sleep, which include REM sleep behavior disorder or RBD, sleep paralysis, and nightmare disorder. Okay, next. REM sleep behavior disorder involve in failure of patient to have atonia. As Brother Faris mentioned about REM sleep, it's explained that during REM sleep, the person will have body paralysis, and however the brain activity will there is a brain activity so that we can have dreams. So in this RBD, because of there's no body paralysis, so patient will literally enact his or her dreams, her dream. So macam because of there's no body paralysis, the dreams will be react by the body. Okay. Patient will presented with punching, kicking, leaping, and running from back, and this act can be correlated with the dream imaginary. In contrast, from sleepwalker, they does not aware about their surrounding. And many drugs have been associated with to worsen the RBD, and for treatment, clonazepam have been used successfully to treat RBD. Next is recurrent isolated sleep paralysis, which is inability to make voluntary movement during sleep. Usually it happens at sleep onset or on awakening, which the person will partially conscious and aware of their surrounding. And it can last from 1 to several minutes. And as the presenter mentioned that this sleep paralysis is tetrad of symptom of narcolepsy. Okay, and sleep paralysis can occur with or without hypnagogia, and if it's happened, the patient will complain of presence of creature, talk, attack, or sit on the sleeper chest and then vanish. And some non-precipitating factor includes irregular sleep, sleep deprivation, psychological stress, and shift work. And the first line therapy of this disorder are to improve sleep hygiene and assurance of adequate sleep. And next is nightmare disorder, which is a frightening or terrifying dream and sometimes called as dream anxiety attack. And it's happened in REM sleep and evolve from long complicated dream and become increasingly frightening. So different from the sleep terror, it's happened in REM. Okay. So if they being awakened, usually the person remember the dream, and in contrast to sleep terror. So this another difference that if they being awakened from the nightmare disorder, they can easily awaken, and when they are awakened, they are conscious. There's no confused state, and the person will remember the frightening dreams. And some experience recurrent nightmare, usually associated with post-traumatic stress disorder, where there may be a recollection of actual events. If the nightmare is frequent and distressing, it may lead to insomnia. And the person who are at risk is developing nightmare disorder is schizotypal, borderline, schizoid personality disorders, schizophrenia, patient with PTSD, patient taking L-Dopa and beta-adrenergic blocker, and person with alcohol or drug abuse. Treatments include behavioral technique, universal sleep hygiene, stimulus control therapy, lucid dream therapy, and cognitive therapy. And medication can be prescribed in patients with PTSD, such as atypical antidepressant and prazosin. So I would like to highlight a few differences, which is the first is um, uh, when it's happened, and in sleep terror usually it's during the non-REM sleep, so it's earlier in the period of sleep, while the nightmare disorder is later stage of sleep at the REM sleep. Next is if it's being awakened in sleep terror, so the person will be in confused state and does not remember the episode. If in nightmare disorder, they easily awaken and they can remember the episode. Okay, next. Is other type of parasomnia include sleep enuresis, catatonia, and sleep related hallucination. Next, sleep enuresis or bedwetting is disorder where the person urinates during sleep while in the bed. there's a primary and secondary form of sleep enuresis. Primary is when the bedwetting continue from infancy, while the secondary form, there is relapsing of bedwetting after toilet training is complete and there was period of the child remain dry. So it happened after a period where the child remain dry. Okay. So usually bedwetting resolve after 6 years old when the child complete toilet training. In primary enuresis, usually parental primary enuresis increase the likelihood of the child to having the same problem. For secondary cause, birth of sibling can be a factor and usually due to seeking for attention. And other secondary cause include nocturnal seizure, sleep deprivation, urological
Hilang
Lagging. Sir.
Oh, she fall asleep. Okay, juga nak habis ni ya. Okay lah, lain baca lah ya. Any question from